Sure. My name is Kelli Stajduhar, and I'm a nurse. I'm a professor in the School of Nursing at the University of Victoria in Canada, and a Canada Research Chair in Palliative Care and Community Health.
Great.
Among other things, I'm also a wife, I'm a mother, but I think we're interested in what we're going to be talking about today. Oftentimes we talk about, we want to work with people, we want to work with patients first, but and I don't even like the word patient, but we don't ask people, what they need from us. And I work in communities of people who are not particularly well served by mainstream palliative care. And definitely what I found in my working community is that the way in which we have designed our services actually don't work very well for most of the people that I'm in contact every day in my work. And it makes it really tough when our services are not designed in ways that, will be helpful to all people. So I think in our clinical work and in our service development, we often uh, think of this, I want to say, standard person that we see in palliative care, which is typically people who are white, middle, or upper class and have cancer. And, that's not the only people when you go into community, you see that there's a whole community of people that actually could really benefit from a palliative approach to care, but in ways that actually work for people. So, I mean, my working community informs everything that I do, from the research projects that I do, from the way in which I interact and relate with people, from the way that I try to advise government on service redesign, because not everybody that enters our palliative care services is a standard patient or standard person.
Would you like to give us a specific example which stands out for you, which exemplifies your approach?
Yeah, I think, what I can say is that, for example, I work with a lot of people who experience homelessness, or maybe precariously housed. And, sometimes what will happen, for example, is, and what a lot of clinicians would not be aware of, is that oftentimes, when people are in those situations and their health declines, they can no longer stay in a shelter or transitional housing because the staffing in those places are not they're not staffed with healthcare people, and they're a little bit afraid of what happens when people decline because it's outside of the scope of their job description to help them. So what happens is somebody declines, 911 or emergency response is called, they're taken to hospital, and maybe whatever issue is happening is resolved, and they are going back out and they find they no longer have housing. And it's so, if you don't understand that, you're sending people back into environments where they're unlikely going to be able to stay, that the only way that you can know that is being in community and observing that firsthand. So, like, I absolutely know people who get evicted because their health is declining. Um, so in some ways, I think, people say, well, that's a problem for the housing sector. No, it's actually a problem for us in palliative care, because if you think about palliative care as being care for the whole person, then we should be thinking about the social determinants of health, and that becomes our intervention in palliative care. There's a lot of people who, I always say in palliative care, we often talk about how, you know, we have to manage people's pain before we can get anything else done. But like, for the folks that I work with, pain is not their first priority. The clinical issues are not the first priority. the first priority for them is getting some food, getting some shelter, and getting some love, to be honest.
And what kind of how have you realigned your services to be able to meet those people where they are?
Yeah, I mean, part of the work we've been doing over the last decade is really trying to figure out, uh, what can we do, and and working with community to do that. So, we have, for example, a very small little program called the Palliative Outreach Resource Team, which is basically a mobile uh, palliative care team that works in community to not to take over the care of people, but actually to build and work within and with community to build capacity for better care for people who are coming to the end of their lives. And a lot of the people that we see don't have good connections to the healthcare system. They actually don't want to go into the healthcare system. And so a lot of our work involves building trust because a lot of people have been harmed, including been harmed in palliative care units, from things like not believing that they have pain. So this little, I'm going to call them the little powerful team, actually works with folks wherever they happen to be. So if they're in a tent encampment, if they're sleeping rough on the street, if they're in a shelter, and I would say the approach we took was very much to was based on some research that we had done, and then saying we actually need to build these services in collaboration with community. And so everything from building out, like, what kind of people do we need on this team? What does the referral process look like that is just so smooth, like no, an absolutely zero barrier referral process? Um, and so I think, and I'm going to say really unbureaucratizing everything. And then just being out there and building trust with the community, building trust with the people that need care, but also building trust with the workers that surround them, because they often have not been well treated when they take their clients into the healthcare system. And so, we did a little study of the first 43 clients that were served by that team, and we had reduced emergency room visits in those 43 patients by 70% and reduced hospital admissions by almost 60%. Like the folks that we work with don't want to go into our mainstream services. So our whole program is designed to meet people where they're at and to work with and in community to do that. And if somebody, like, for example, so I'll tell this story of there was a guy that was being served by the team who was really, really having some pretty significant pain issues. And the physician on our team, Dr. Fraser Black, was working with him, and he really didn't want to go into hospital. And Fraser, said, like, I'm having a really hard time getting on top of your pain while you're living in your car. And so over, a series of visits and weeks and just keep going back, the guy said, okay. And he said, because his pain was like pretty bad, but his primary worry was what would happen with his car, because that was his home, and everything that was in his car was home for him. And so what the team did was, at night, this guy used to park the car in the parking lot of a gas service station, and he had gotten to know the nighttime attendant. So, the team would go talk to the nighttime attendant at the gas station, And the guy said, yeah, he can, we can leave his car here at night or whatever until we find another place to park it. And then, so like the team is organizing parking so the guy doesn't lose his car. The team is also getting the only way the guy would go into hospital to get his pain managed is if all the contents of the car could come with him to the hospital. So, they were working with community workers to say, let's pack up this guy's car, let's find a place to park it. So that became the primary intervention before we could even focus on the pain. And so what I would say about that team is it's like maximum flexibility. And and also, because we have these very deep relationships with workers in the community, we can just call somebody up and say, hey, so and so we need help in getting their car unpacked and getting stuff, to the hospital, or the team will do it themselves in the absence of anybody else. So, it's just whatever is going to work for that person to get the care they need. And you
And
only know that. So,
do,
you only know that if you're in community and
yeah,
you
yeah.
and you understand what's important for people.
And do you have some examples of um, community capacity building where you might talk about death literacy, or where communities have actually taken over looking after people through um, through building their capacity to do that?
Yeah. Yeah, I mean, right now, we've just had a request, for example, one of the kind of low barrier housing facilities want to teach their staff how to do advanced care planning. And they want to do that because for a lot of folks that we work with, they don't have a lot of contact with biolegal family. Nobody is talking to people about what they want. So like we do that kind of capacity building. We'll do things like, take um, in the moment teaching opportunities, for example, to work with housing staff to say, how do you notice signs of decline? Like they're not necessarily going to understand trajectories and well, they can. I mean, we think about working with housing staff much like we think about working with family, but I think the challenge a little bit is that they have a certain job role and they're not allowed to do certain things. Many workers do because because they feel a moral imperative to do so. But they're also the workers are also have little power in their organizations. They're the lowest paid workers, and so they don't. It's a bit of a risk to step outside of their job roles. So the latest conversation we're in is, can we create a program where, we're teaching mental health and addictions workers to actually develop and be allowed to develop some physical care because people want to keep their folks in their communities. So, that's kind of our latest, that's one of our latest kind of like, okay, let's see if we can do this to get some of the restrictions on them pulled if that's what they so desire. But I mean, the team, we're all out in community, and I wouldn't say like we have tried to do things like, oh, let's do a workshop for housing workers. That doesn't work that well. Like it's that in the moment kind of like we got somebody that we're supporting and we're looking after, and how do we actually work together and and really helping folks to understand what's going on. Like the workers that we work with are so relieved when the team is involved because a lot of people are afraid of death, even though it's all around them all the time. They desperately want their clients to get good care, and they often don't. And so, I think the team works in a very kind of, I want to say, stepping in slowly and building at the speed of trust, like, but a very nuanced individualized approach that actually builds trust. And, I think to myself, uh, we had a visitor here from New Zealand the other day, and she was out with the one of the physicians on our team, Fraser Black, and she came back. We were having dinner, and she said to me, I said, "How did it go?" And she said, "He's like a celebrity. Like every single street involved person knows him." And it's like, yeah, because he is out there, he's trusted. Everybody, knows this team. But, we've been a decade building those relationships so that, and the workers know us too. And so we don't want to, we're not taking over what they're doing. We're trying to supplement and provide uh, what is needed that isn't in the scopes of their roles, and building that capacity. So, I mean, why can't a housing worker do advanced care planning? Why not?
Yeah.
They have these conversations with people all the time.
One of the things that Nahid talks about is street family and about kind of
Yeah,
working with street family so that they
yeah,
can look after the people who
yeah,
are going through, the experience of death, dying, loss, and caregiving. Do
yeah.
you have programs where that happens?
Yeah, well, for sure, we see street family all the time. And we often have, like, you might live in a single room occupancy hotel and you've got a friend down the hall that comes and, helps you with certain things. And like we would never want to stop that. Like, we'd want to promote that. Um, in the groups that we work with, sometimes there's one or two people that are like that, but I mean, the other reality is that it's a lot of relationships in the street community are very transactional. And so there are people that come in and out of people's lives. And so, sometimes there's a stable one or two people in somebody's lives, and sometimes, it's not the case. Or we had a gentleman, for example, who was being served by our team, who, had like somebody in his life that was very important to him, and they supported each other. And then this guy got a bed in a facility that was, probably a 10 to 15-minute bus ride away, and all of a sudden he loses those connections. And so, the friend is like going to see him and stuff, but then the staff doesn't like, because it's in a long-term care home, the staff doesn't like how rough he looks and everything. And he ended up leaving because what he wanted the most was, he might have been getting his physical care needs attended to, but what he wanted the most was that reconnection with his community and the people that supported him. So, like, I do think that for sure, in cases where there's some stability, like, we're really working to really support those folks to continue to care in the ways that they are, and not disrupt that. And even, are there ways to augment that? And that's always the goal. The goal is always to meet people where they're at, to keep things going in a way that works for them, and we'll fill in where we need to. But you don't want to disrupt that kind of sense of community. The minute that we step in and say we're the experts is, it's a problem, because all the other people feel, disengaged in the natural care that they were already giving. And it's a very, very embedded part of how we work, not to disrupt, and to really try to bolster those kind of community relationships and connections.
And as a palliative care clinician, what is it you felt you have gained through um, working in community settings?
Uh, oh my God, there's so many things I've gained. I mean, it is it has completely uh shifted my whole way of thinking about how to care for people as a nurse. And I think I told you that story before, that I began my nursing career in the middle of the AIDS epidemic, and that's the work I was doing. And at that time in the 1980s, I mean, healthcare people didn't want to care for people with AIDS. So communities had to look after themselves. And, when you watch that happen and you're embedded in that, you learn very quickly how to step aside when you're not needed. And I think probably the biggest learning for me was how do I put my own ego and need to help like to the side? Like that experience really caused me to reflect pretty deeply on like whose needs am I serving? Because I think sometimes in palliative care, we can get into this kind of situation where we think we're the only people who can do this. And I don't think that's the case at all. And I think that we have certain tools to offer in certain situations. But for the most part, I think communities do a pretty good job of looking after their own. And the things that they can't do are the places where we should be stepping in if we have permission to do so. So I think it's really instilled in me a deep sense of humility, a deep sense of like letting things unfold as they are, and I'm kind of there as the backup, the backup singers to what is naturally occurring.
Times palliative care services, but the things that palliative care services do are not just they're not just things that could be done by community. They're things that could be best done by community,
And for
not to the
sure.
palliative care services.
Yeah,
So can you stick that
for
into your own words?
for sure. I mean, I see this a lot in um grief work, for example. Like, and I think I was telling you earlier about, this work that one of my students was doing with youth, and, youth and grief and, street involvement, and it's like, oh my gosh, if we would have thrown grief counselors at these kids, it would have been a disaster. It actually would have been harmful, because they had created communities all around themselves to talk about these really hard issues. And I think that we can't step in when we're not needed. It's actually can be harmful to community to do that. And how communities do things might not look the way that we think in as a clinician they should be done. But I don't know, who are we to decide what is best for people? Like I do think that there's this profound power differential between people who are the deliver healthcare and those who receive it. And communities, for a lot of instances, can do just fine on their own around issues of loss and grief, and even care of the body. People might find different ways to manage pain. So and for sure, like we work with a lot of people who use drugs, and people are self-medicating, and sometimes it just works like fine. And so, we're not going to disrupt that. Why would we disrupt that? And when maybe it's not working fine, then maybe we're, with a trusted clinician, maybe we're able to manage pain in ways that, help people not use drugs that might be actually unsafe. So, like, there's a lot of nuance to the work. There's a lot of like really like our best allies are people in community. They're the people who know folks best. And I think if healthcare providers think that they really like know the person, they're mistaken, because we know that most people hide lots of things from us. So we don't always get the full story. but people in community know. And for sure, they can be capacitated to care. Many people want to be capacitated to care. We had a man that was a participant in one of our research studies, and he lived in a building, and there were like, well, he had cared for about five people who were declining and dying. And he didn't even like some of these people, but he'd say, I'm going to help people because I did a bunch of wrong things in my life, and I'm going to do things to support them and make sure that they're okay. Just a guy living in a building wanting to find meaning in his own life. Why would we stop that? It's good. It was good for them. It was good for him. And the team just kind of wrapped around him and said, "What can we do to actually support you?" You
What you
have to
said.
you have to be in community to see these things. Like,
Yeah.
it's not like people are coming up to you and saying, "Hey, I'm caring for five people who are dying." The only way you know that is if you've got boots on the ground and you're in community building relationships and building trust, and then people get to know you, people get to trust you, and then you're learning about what people need. And sometimes we'll say, like our team, for example, the social worker on our team said to me the other day, she said, "I spent a lot of my time at the coffee shop just talking to people." And, some people might say, "Well, you're a social worker, like you should be doing X, Y, and Z." And she's like, "No, my work's in a coffee shop with people and trying to figure out what they need, getting to know them, getting to develop a relationship with them. We have to, in our services, we have to get out of the idea that there's right skills to do things, or we have to do certain things, you know. It's relational, it's nuanced, it's relational, and the only way that you can serve community is by getting to know them. And the only way you can do that is to be in community and
Brilliant.
listen and
Brilliant.
listen.